Alright, so Pharmacist Interventions Part 9. In this video I'm going to talk about the most common prescription errors that I see and then my interventions on them. So first one I see involves nitrofurantoin, which is the most commonly prescribed antibiotic for UTIs. It's first-line therapy. It comes in 2 formulations, macrodantin, which is dosed every 6 hours, so 4 times a day, and then macrobid, which is dosed every 12 hours or twice a day. So I see a lot of practitioners sending in macrodantin and dosing it like macrobid. So they'll send in macrodantin and then dose it twice a day. So you're not really hitting that bug for that full 12 hours. You're hitting it for 6 hours with the macrodantin. 6 hours you're not hitting the bug. So it might not treat the infection if you're dosing macrodantin like macrobid. Second most common error I see is practitioners prescribing the topical metronidazole gel for vaginal usage. This is the vaginal formulation. It's for bacterial vaginosis. It's supposed to be used nightly at bedtime for 5 days. And practitioners will electronically prescribe that topical formulation. The system will input that topical formulation, and then the technicians will push it to the pharmacist because they don't know better. And then upon verification, I'll notice that it's the topical formulation and the field for the drug, and then the instructions of use vaginally for 5 days. So I will have to reject that prescription, go back, edit it, put in the vaginal formulation, and then push it through as that, because that's what was supposed to be prescribed. I've had a couple patients actually pick up the topical formulation. I think only one has used topical formulation vaginally, and I'm not sure how they did that because this one comes with applicators for usage, and the other one did not. Another common prescription error I see is practitioners sending over dual SSRI therapy or SNRI therapy inappropriately. This is usually either a different practitioner or we're switching the patient to a different one, but there aren't any notes saying discontinue the Lexapro, discontinue the Prozac, patient switching to this drug. So I had a patient a few days ago who was switched to duloxetine from Lexapro. They were already on the max dose of Lexapro, and they were also on Remeron and Trazodone. So Trazodone is an SSRI, and Remeron is not, mirtazapine is not an SSRI, but it blocks alpha-2 receptors, which is a hetero and an autoreceptor. So it increases serotonin and norepinephrine output. So it does increase serotonin. So I asked him which one he's supposed to be on. He didn't know. So I recommended stopping the Lexapro and talking to the doctor about probably he's supposed to be taking the Cymbalta as a new medication. This happens also with long-acting insulins a lot, so Basaglar, Tresiba, Levemir, I'll see dual therapy. Patients don't know better and think they're supposed to be on both of them, and there usually aren't notes saying discontinue the other insulin. So I'm going to have to sift that out with the provider to make sure that they don't overdose on their medications.